Thank you to all the participants on Zoom and for those here in person. We'll go ahead and get started. Do we have our speaker for next month?
Yes, it's gonna be on Zoom only though, because she's overseas.
Okay. Who is it though? All right, we will have a Zoom speaker next month in our seminar. Just was going to promote that, but we'll get that in a second. As we introduce Dr. May, who, as it says here, is associate professor. But what you may not know is this started in July. So the newly appointed associate professor in the School of Medicine. So Dr. May started. I don't think you guys overlap. When did you go to Duke?
2012 to 2016.
Yep, did not. Uh, So Dr. May got her Bachelor of Science uh, from Duke University, and then she went on to Washington University in St. Louis to get her MD. She then came here. That's where we had first met when she was trying to figure out how she could do things that were not in the malignant realm. And she decided to pursue a career in classical hematology. And so we are extremely excited that she not only did her fellowship here, but stayed for instructor, assistant professor, and now newly appointed associate professor. Um, and lest I not forget, she was a chief resident as well. I forgot about that. I apologize. So she again has she's a classical hematologist focusing on patients with usually with thrombosis and coagulation disorders, and has an interest, according to UAB profile, in system-based hematology, which is a field that works to improve hematologic care delivery across the health system. So she has a nice publication record, including, according to our little circles that we have, the biggest circle is with Dr. Marquez. So again, some of this coagulation expertise. Uh, and we're letting people in, or you want me to let them in? Letting in Dr. Rye, Dr. MacArthur. You got the, all right. You're able to let the people in? Okay, perfect. All right. And with that, excited to hear your presentation today. Thank you.
Thank you, and thank you for the overly kind introduction, but I'm really happy to be here, and as you mentioned, I am classical hematologist, but really focusing in thrombosis, and so what I thought we would talk a little bit about today is just outpatient VTE management, certainly, and highlighting some things that would be specific to the sickle cell community. And hopefully this can be interactive. I'm going to try and watch the chat. Feel free to put in questions. I have time, not going to use all the time talking, hopefully having some nice discussion if there's appetite for that. So there we go. So what I'm going to talk about today is kind of the diagnosis and management of VTE. Some of the things we want to be thinking about clinically. So when you have a new patient with VTE, what do you need to know about the clot and what do you need to know about the patient in order to determine best management? And so in management, we're going to talk on things like agent selection, the duration of anticoagulation, and some common questions that I get are, do you need repeat imaging? Do you need thrombophilia testing? And do you need an IVC filter? So let's start with what do we want to know about a clot? So when we're talking about VTE, if we first talk about the extremity, it's really important that we actually dig in a little bit deeper in the ultrasound report to understand what we're dealing with. So I think most in the clinical space are aware that we think about deep venous thrombosis versus superficial veins differently. So those superficial clots we're less concerned about, don't have that ability to embolize to cause pulmonary embolism, as opposed to those VTEs in the deep circulation. You have to be careful. Actually, there's a historical holdover that the femoral vein used to be referred to as the superficial femoral vein, which is very confusing. It is very much not a superficial vein, but you will sometimes still see that terminology on your ultrasound reports. If you do have a superficial vein, we actually do pay attention to the proximity to the deep junction because, right, all of those veins drain together. And so if you have a superficial vein that's really close to that junction, sometimes we'll even treat it as a deep venous thrombosis. The other distinction that we think about is distal or proximal DVTs. And so proximal refers to above the knee, distal refers to below the knee. And that has some considerations in management when we think about duration of anticoagulation and really thinking about there's a lower risk for recurrence and embolization in a distal DVT as opposed to a proximal. The other thing that's really important to think about is it old or new? And this comes up a lot in my practice is when I explain the evolution of thrombosis to patients, I often equate it to if you cut yourself, the difference between a scab and a scar. So when you have a fresh cut, you have this scab, which is kind of soft. It has the ability to break off and move. But over time, that becomes scar tissue, right? It's adherent to your skin. It's not going anywhere. The same thing really happens within your blood vessel, and it gets a little bit confusing because radiology often will still call it a clot. So it's really important for us to understand is that finding within the blood vessel, is that an acute clot, something new, that scab that we're worried about needs anticoagulation, has the ability to break off and travel, versus chronic, which I think of as scar tissue. So acute clot does have specific appearance on ultrasound. In general, the vein is dilated, so it's reacting to that area of obstruction. The clot itself tends to be spongy, so it's soft and it's hypoechoic. As opposed to a chronic clot or scar tissue, here we see the vein is usually scarred, it's retracted. The clot itself, it tends to be firm and hyperechoic. And I will say you often won't get this level of detail in your report, but if you pick up the phone and talk to your radiologist, that to me is the best way to ultimately help distinguish if you have uncertainty of whether this is new or old. What about pulmonary embolism, and what do we need to know about the location of the clot in the pulmonary circulation? Right, just remembering that we care more about these kind of bigger clots in the larger vessels versus the more distal clots. And the other thing is that CTA is kind of less accurate when you're getting into particularly subsegmental arteries. So understanding where you are in the pulmonary circulation can be helpful, and just remembering that CTA really isn't perfect. So you can see the sensitivity and specificity that's reported here. And so it's not 100% either way. So if you have really high clinical suspicion, even if your CTA doesn't show PE, then you can think about additional testing to investigate. Or if you see an isolated subsegmental PE that doesn't fit with your clinical picture, that could also be that the CTA is inaccurate. So important to have a level of question and that you're looking at the patient in front of you, the radiologist is not. And when we talk about PE, you'll often see this terminology now is that we think about the clinical severity. And so this is from the European Society of Cardiology guidelines and is kind of widely accepted when we think about low risk pulmonary embolism versus what we call intermediate and high risk. And the reason that that's important is that people with low risk pulmonary embolism have an extremely low risk of PE related mortality. And those are people that often we don't even need to admit to the hospital. We can just kind of treat them with anticoagulation and monitor them closely. As opposed to these patients that have more concerning risk factors, those are patients that get admitted or may even require interventions such as thrombectomy or even systemic lysis. And so what are the criteria that we need to know about a patient with a pulmonary embolism? We want to look at their hemodynamics, obviously. There's something called the PESI score or the simplified PESI score, which again, it helps predict mortality from PE. So these patients have a very low PESI score or a simplified PESI score of 0. They don't have any evidence of right ventricular dysfunction, and you don't have to check troponins, but theoretically they would have negative troponins. And so from there, that's where the risk rises. So this distinction can be really important when you're making clinical decisions. And so the other question of is it old or new, kind of like we asked in the DVT space, you know, a CTA really can't tell you. Some radiologists, again, think that they can, but it's a little bit harder to know, right? You can't push on it. You can't really do anything to it. So it's a little bit harder to tell. I will say there are some features of maybe adherence to the wall when you look at a large vessel pulmonary embolism, but particularly for those smaller vessels, you really can't tell the acuity. Ideally, you can compare to old images. That's our best way to know if something is new or old. So what do we need to know about our patient? So we found out they have a clot. What are the things that we want to make sure we're collecting as we're talking to a patient of what are, understanding why a clot could have happened, what are their risk factors for thrombosis, but also thinking about what their risk factors are for bleeding, because theoretically we're starting anticoagulation, and so we want to be proactive about any bleeding risk. And so what are our kind of known and documented thrombotic risk factors? We all feel pretty comfortable with major surgery, which is anesthesia time greater than 30 minutes, traumatic injuries, particularly long bone fractures, pregnancy and the postpartum state for 6 weeks after delivery. Immobility is a soft one. And I get this question a lot of how much immobility is considered a risk factor. And in my practice, it has to be a pretty significant amount of immobility. So you can see here for travel, there is some data on this. So if you are on a flight greater than 4 hours, your risk of VTE is 1 in 4,656. So rare, but possible. Greater than 8 hours, it's less than 1%. And really, this should be in that earlier period of time after a trip, so within 8 weeks, as opposed to surgery where that kind of window expands out to 3 months. So you have to be pretty immobile. And I ask people a lot of weird, detailed questions of, okay, you were on an 8-hour flight, but did you get up like 5 times to pee, or did you sit like this without reclining for 8 hours without moving? But it takes, in my practice, a really high threshold for immobility before I call that a kind of major provoking factor. If you've had a clot before, you're more likely to have one again. So understanding previous history, other medical problems, things like cancer, inflammatory bowel disease, nephrotic syndrome. COVID comes up. Is that a risk factor for VTE? I will say in my practice, with the current strains of the virus, unless a patient is hospitalized, I would not consider this a risk factor for VTE. With the earlier strains of the virus, absolutely. We saw massive thrombosis, but currently we really don't. Most people, it's kind of just a viral illness and we ride it out, but we don't necessarily see that increased risk. Different medications to think about. So we know that estrogen increases thrombotic risk. Testosterone is a little bit on the softer side, but we do think that testosterone increases risk. Certain cancer-directed therapies that we know of, like tamoxifen and bevacizumab, are associated with increased risk. So making sure that you're thinking about those medicines that your patient's taking. Family history is important too. And I always kind of explain it to trainees is just saying a family history is negative is not particularly helpful. I want to know, how many siblings do you have? Do you actually know about your parents' medical history, or have you not had contact with those family members? If you have multiple family members and you know about their medical history and they've never had VTE, that's a lot more reassuring as someone who's like, well, I don't really talk to my mom and dad. I don't know if they've had any medical problems. In social history, we know that tobacco use increases thrombotic risk. Thinking about what they do, I ask all my patients, like, what does your everyday look like? Are you sitting in Zoom meetings for 8 hours straight? Or, do you work in a factory where you often cut yourself, or I'm concerned about bleeding issues? And then on exam, we're looking for things like obesity, which increase thrombotic risk. We're looking for signs of occult malignancy. For bleeding risk factors, what are things that we want to be asking our patients about? Have they had any issues with previous bleeding, any recent surgeries, malignancies, frequent falls, all things that might increase their bleeding risk? If they're on any other antiplatelet therapies, so often aspirin finds its way onto people's medications list, and does that need to be there? Or are they taking a lot of NSAIDs that you worry about GI bleeding risk as well? Thinking about their high-risk behaviors for traumatic injury is really the most common reason we develop bleeding problems on anticoagulation. So, are they riding four-wheelers on the weekends? Like, I want to know about all those things. Looking at their labs to make sure they don't have an existing thrombocytopenia or a coagulopathy. There is a validated bleeding risk score for the VTE space. You may be more familiar with atrial fibrillation. We have the HAS-BLED score and all sorts of more validated tools, but this is one that I use that's been validated in VTE. And not that I would ever use this to say a patient shouldn't be anticoagulated, but more it triggers in my mind, what are those modifiable risk factors that I might think about in a patient that I'm starting on anticoagulation? The biggest things that jump out to me are people who have uncontrolled blood pressure. This particularly showed up in men, but higher blood pressure increases the risk of things like intracranial hemorrhage. Anemia is going to be many of our sickle cell patients, and probably we're not fully participating in the validation of this score. Do they have a history of bleeding? Do they have existing renal dysfunction? And are they older? So those are all things to think about. Again, not that you're going to not give someone anticoagulation, but just acknowledging that they may be at increased risk. So that's diagnosis. I'll pause there for a second. That's usually doesn't generate too much discussion, but any thoughts, questions, things that you do differently?
Yeah, I don't know if
Yeah.
we can get into like more specific sickle cell disease, but
Mhm.
prior to here, I was at Texas Children's Hospital, and we did some retrospective reviews and showed that those with sickle cell disease, granted this is pediatric population, who had acute chest syndrome, a line, or were in the ICU.
Mhm.
More specifically, AAP,
Mm,
also just VTE in general.
yep.
So, wanted to see if you had any thoughts in terms of, and so because of that data, we actually anticoagulated all patients over the age of 12 who had acute chest syndrome
Okay.
and or a line if they were in the ICU, and they were less than 12 with 2 risk factors, and then any kid over 16 we would coagulate if they were admitted. So any thoughts?
Yes. And so like prophylactic anticoagulation. Yes, absolutely. So, and I didn't give the premise, the caveat that I am very much an adult hematologist. So I will defer to you on the pediatric space, but no, we definitely see that in the adult population. And so in our inpatient sickle cell patients, we recognize that sickle cell disease itself is an increased risk factor for VTE. And so routinely recommending basically all of those patients, even with kind of non-critical medical illness, often recommending VTE prophylaxis. And I think having a conversation with the patient about why they're getting that too, because the other thing that we run into is just remembering that prophylaxis is an injection, which is not something that is ever enjoyable. And so we run into issues with people refusing that if they don't fully understand why we think that that's indicated. So absolutely.
We expanded to being able to routinely give rivaroxaban as an alternative, and so that was way more accepted.
I bet, and particularly in the pediatric population, that's fantastic to be. And I should repeat to the Zoom audience, I'm sorry. And could you tell me your name?
It's here now.
Tell me your name one more time. Shani Anum. It's so nice to meet you. Asked a great question, is telling me about her experience with VTE prophylaxis for children admitted with acute chest or central lines. And that, we do that in the adult population, and switching to an oral agent is really nice. The adult population has really not, or the adult kind of care environment, we really have not moved to oral. There's so much concern about bleeding. And so I think we all have this hesitation that and I'm not saying that that's validated, that like if we give an oral agent, like it's going to hang around longer, but we know that the DOACs wear off so quickly. So that's a very reasonable option, but I will say there's not as much adoption in the adult space. But great point.
Yeah. Going on what, their data was showing, it always makes me concerned. We have our acute chest syndrome kids who are just, really having trouble breathing, we're like, oh, acute chest. But whether or not we should be getting more CTAs looking for PE, because I assume the adult sickle cell patients would have more PE
Than in kids.
But again, it's whether that's just an underreported phenomenon because you just blame everything on the acute chest syndrome.
Right.
As opposed to does the kid also have or does the adult also have a PE?
Right.
At this time. So
well,
doing CTAs on?
So it's so interesting. During my fellowship, Dr. Cantor and I did kind of a retrospective look at evaluation for PE in patients with sickle cell in the adult population. And we actually worry about overscanning, right? That like anybody who comes in with hypoxia gets a CTA, and that may or may not be necessary. And the challenge is that in the adult population, the risk stratification strategies that we use rely on D-dimer, right? Which is going to be elevated in a patient with sickle cell disease. So we tried to look at kind of how traditional risk stratification tools function within the adult sickle cell population. So we often consider it, but I think actually in the adult space, we probably struggle with overscanning rather than underscanning, just because of the risk of, AKI with contrast exposure and everything like that. Yeah, all great questions. Other thoughts or questions from the Zoom folks? Great. So I'll jump in to kind of management, just because, again, these are kind of the biggest questions that I get. And this is we're going to go through this slide line by line. But basically the questions of how do we pick anticoagulants? And it seems like it should be straightforward, but it's really not. And that may be my bias because I'm really interested in kind of questions of how we use anticoagulation in health systems. But there's a lot of nuance to picking the right anticoagulant. In general, for people with sickle cell, like there's not any sort of agent that's preferred. So it's really going to be consideration of their comorbidities, just as you would in any patient that you're starting on anticoagulation. So everything here is the same thing that I say for any patient that I treat with anticoagulation for VTE. So the specific populations to think about are patients with malignancy. So in general, for a long time, we were only using low molecular weight heparins. We're really comfortable with the direct oral anticoagulants now, but there's some concern that the DOACs are associated with increased bleeding at anybody who's got an intraluminal mass. So like if they've got a big GI malignancy, they've got a big GU malignancy. In general, I say maybe in that initial period of time before they start treatment using low molecular weight heparin, but ultimately getting those folks on DOACs if that mass is ultimately controlled. There's been a lot of attention to antiphospholipid syndrome and the fact that data has shown a higher risk of particularly arterial thrombosis with the direct oral anticoagulant. So warfarin tends to be preferred. There's still a lot of debate about this in the hematology community. And in my practice, I sometimes have patients who really just can't be on warfarin, or really their time in therapeutic range is so low that I often make the risk calculation and put them on direct oral anticoagulant. And sometimes we'll add an aspirin. That's never really been evaluated in the APS space, but just something that comes up. People with severe renal dysfunction. For a long time, we weren't sure what to do with these folks. We now feel really comfortable using the DOACs. We prefer apixaban over rivaroxaban just because it is less dependent on renal clearance. Importantly, in the VTE space, we don't dose reduce for renal dysfunction. If I have a patient that has, severe renal dysfunction, maybe I'll be less hesitant to use that initiation dose of the 10 milligrams twice a day for the first 7 days after a VTE, but I will keep them on the 5 milligrams twice a day, which is the standard dose for that initial 6 months. People with severe liver disease and coagulopathy in general, low molecular weight heparin is preferred, but DOACs or warfarin can be considered in compensated disease. There are some medications that interfere with the DOACs, much less than warfarin, but there are a few old like anti-seizure medications that come up. But just remembering that edoxaban actually has a different metabolism than the other DOACs, so it can sometimes be an option. People in high risk of bleeding, and I'll have to update this. So in general, we are favoring apixaban. I'm going to go over, there was a recently published or presented trial at ISTH really kind of supporting that apixaban has a lower bleeding risk than rivaroxaban. So in general, in patients with sickle cell that are complex, I think apixaban would be my preferred choice, and I have no disclosures, I promise. I wish apixaban would fund me. Heavy menstrual bleeding, there actually is data that dabigatran has the best profile for people with heavy menstrual bleeding, but then second to that would consider apixaban, definitely better than rivaroxaban. But just remembering, if you have a patient, basically any patient who menstruates that you're starting on anticoagulation, talking about menstrual bleeding and remembering that we have other great ways to kind of decrease menstrual bleeding, including hormonal contraceptives, IUDs, tranexamic acid, beyond just the anticoagulant selection itself. For a long time, there was hesitation about using the direct oral anticoagulants in people who are obese. We have kind of data now that suggests it's probably safe, and kind of the threshold. These thresholds were defined by the ISTH of, a weight greater than 120, BMI greater than 40. A DOAC's probably okay. I will say I start to get nervous if I'm at a BMI of like 55, 60. Sometimes in those initial period of times, I'll put them on warfarin for a short 3 months and then switch them to a DOAC. Anybody who's had any sort of gastric surgeries, bowel resections, really we prefer warfarin or low molecular weight heparin, but the direct oral anticoagulants can be used maybe with checking a trough level into it to evaluate for absorption. Some other things to think about is when you might pick an alternative agent. The biggest time I'm using rivaroxaban is when I have a patient that prefers once daily therapy, which is a lot of patients. And so I have a very frank conversation with them, particularly if someone is otherwise of a lower bleeding risk. Getting them to take apixaban twice a day can be really challenging. And so just remembering rivaroxaban is a once daily option. And for a long time, we said, well, cost and coverage, we would have to think about warfarin. But in general, I have the very rare patient that I'm not able to find a way to make a direct oral anticoagulant affordable for them. I'm not sure how it is on the children's side, but over at UAB, because of our 340B status, you can get rivaroxaban for like a penny a day. And so our social workers are often able to pay for it if we run into issues. Questions or thoughts on that? Yes.
For the associated BTE, because I know there's a lot of data that's discuss like preferring apixaban like of choice. Is that kind of how you approach it in your?
That is my practice for malignancy associated VT and just VT in general. And that's actually as a perfect lead into the COBRA trial. Yes. So I recently had this. So we now, for a long time, we had this like hypotheses and we were extrapolating of comparing apixaban and rivaroxaban. And so we have our first randomized controlled trial that compared apixaban to rivaroxaban. I will say this is only as a late breaking abstract from ISTH. We don't have the full manuscript yet. So from previous intertrial comparisons of phase 3 data, there was the suggestion that apixaban had a lower bleeding risk with similar VTE prevention risks. So the initial trials, the Einstein trial and in rivaroxaban and the amplified trial in apixaban, they basically showed, non-inferiority when comparing rivaroxaban to VKAs and apixaban to VKAs. But what you can see here is that the reporting bleeding rates were very similar between rivaroxaban and VKAs, but you can see 4.3% here for apixaban. Again, this is inter-trial, but all of these theories started to develop. And so ultimately, this was the first randomized comparison with over 2,000 patients. These were not in malignancy patients, although, again, I often extrapolate. But in general, these people did not have a lot of renal dysfunction. They tended to be on the lower BMI side. And you can see here only a small amount were on antiplatelet agents. But ultimately, the primary outcome was adjudicated clinically relevant bleeding, so major bleeding and clinically relevant non-major bleeding. And then secondary outcomes, you can see here, bleeding outcomes. And then they looked at recurrent VTE and VTE-related death and all-cause mortality. This was just in the first 3 months, the treatment phase for VTE. So that's important to think about. But let me show you the numbers. So if you look at for clinically relevant bleeding, we saw 3.3% in the apixaban population versus 7.2% in the rivaroxaban population. So quite significant differences in major bleeding and clinically relevant non-major bleeding. There were no events of fatal bleeding. And you can see that the VTE recurrence rate was about the same at 1%. And the all-cause mortality was the same as well. This is from the authors, which I thought was really powerful. They said any inconvenience of twice daily apixaban dosing compared to once daily rivaroxaban is offset by more than 50% reduction in the risk of bleeding, which is true. But again, I do think that there are still patients where I will use rivaroxaban. So I think it's just really important to individualize. But the way I think about it is that my default is maybe apixaban. And then from there, I think about rivaroxaban if there are specific considerations. Again, primarily being consistently taking it twice daily. Questions on COBRA? The other thing to mention, and so there was some things that were brought up in the session of basically, because this was the first 3 months, if you remember, when you have a VTE indication, apixaban is given at an increased dose of 10 milligrams twice a day for 7 days, and then transition to 5 milligrams twice a day. And rivaroxaban is given at an increased dose of 15 milligrams twice a day for 21 days, so a longer period of time, and then transition to 20 milligrams daily. So the thought is, well, is that the reason, is that they have this longer lead-in period? But the data did show an early separation of the curves, but that separation really continued. So it wasn't just about that initiation dose. It even persisted after that. So just something to keep in mind. So anticoagulation duration. This one is really tricky. And I think in particular within the sickle cell population, we're often thinking about the sickle cell disease itself being a risk factor for VTE. So unless there's something that's clearly a provoking factor that clearly resolves, these are people you're probably considering for anticoagulation indefinitely. But I certainly look to this audience and to learn from you if there are certain things that might guide you one way or another. This is kind of the standard algorithm that I use. I think there's important things to extrapolate to the sickle cell population, but maybe lots of things that don't apply, which I think is important to recognize. So the biggest thing is, so people with an isolated distal DVT, really in people without cancer, we talk about a limited duration anticoagulation. But I almost think of sickle cell disease in this hypercoagulable population that I would not consider kind of limited duration anticoagulation for a distal DVT in a patient with sickle cell. But interested to hear if others think differently. So again, I kind of would think in this population that if they're, considering that an ongoing factor. But if they have a transient risk factor, right, those are the people theoretically that we would treat only for 3 months and then stop anticoagulation. So maybe that's a patient that does, get it admitted to the hospital and have kind of a massive episode of acute chest with a prolonged ICU stay developed while they're in the ICU. That patient maybe has a limited duration, but of course you would then need to be really aggressive with prophylaxis in the future for that patient versus someone that, maybe had that 8-hour plane ride that we were talking about. Like that to me in a patient with sickle cell would be a reason to continue anticoagulation just because I would be so concerned about the risk for recurrence. You can see here that if you have an unprovoked proximal DVT or PE, this talks about kind of a risk stratification strategy that I tend to use using D-dimer and antiphospholipid serologies, but obviously we can't use that in our sickle cell patients. So we just really don't have those tools for risk stratification that we maybe have in people without sickle cell disease. And so that's what makes these decisions a lot more challenging. But in general, in the general population as well, it's never wrong to keep someone with an unprovoked event on indefinite anticoagulation. That's the default right answer. It's just more we're trying to find ways to select for those patients that may have a lower risk. And we just don't have those risk selection tools that we do in the sickle cell space. I'll pause. Any thoughts, or kind of interested to hear if anybody has thoughts different than what I've expressed to you? Open for, yeah.
Yeah, so for the ASH guidelines, I think a lot of it's based on the California data. And so what they're saying is first unprovoked or second provoked indefinite anticoagulation. And then and these are all suggestions, they're not recommended, there's evidence to rise to the level of recommendation. And then for provoked, they said 3 to 6 months over indefinite, with the caveat being, but the provoking risk factor is still present, for example, central line. So then keep it on.
Yeah.
If they still have that central line.
Right.
But again, all these were suggestions based on limited.
For quality data. Yeah.
Again, significant need for expertise in the thrombosis sickle cell adult space to answer these questions, because the data just wasn't really strong out there.
Yeah, that's super helpful. Yeah, great. This again is just highlighting there are more tools in development, again, not specific to your population, but this is a nice tool in the general population that gives you kind of a visual summary of the bleeding and thrombotic risk together. If you've ever checked it out, it's worth looking at. And it is really very helpful for shared decision-making with the patient, because it kind of gives visual representations of what the risk of thrombosis is or the risk of bleeding is. Again, cannot be perfectly extrapolated, but just something that just to be aware of that exists. The other questions that come up is, so repeat imaging. And my short answer is you don't need repeat imaging. So the importance here is that in the kind of thrombosis space, appearance on imaging and this idea of the presence of residual thrombosis does not change anticoagulation duration or management. Okay, so we don't ultrasound to see if the clot is gone. That's a question we get a lot of times from patients, because remember, I talked about the fact that kind of you have a scab and then it becomes scar tissue. And sometimes you look and there's no scar that's visible. And so they say there's no clot there. Sometimes you look and there is kind of a residual abnormality within the blood vessel wall, but it doesn't have that same ability to break off and travel. It's just that that vein is damaged. And so it really doesn't affect our clinical decision-making. So I do not, for DVT, get repeat ultrasounds really for any reason, aside from if I'm stopping anticoagulation. So the guidelines from the International Society of Thrombosis and Hemostasis basically show or recommend that if you're stopping anticoagulation, whether that was for a provoked event or it was a weak provoking factor and you ultimately make the decision to stop, you get an ultrasound basically to serve as a baseline for comparison in case of new symptoms. And there was a really interesting study that showed a lower risk of recurrence in people who had a baseline. And it wasn't that the ultrasound was somehow therapeutic. It was just it served as a baseline to say, hey, this finding that you have, even though your symptoms of your post-thrombotic symptoms are flaring up, it's not a new clot. It's been there before. You can safely continue off anticoagulation. So I think this is a really nice tool and something that often gets forgotten. But when you really will thank yourself when you have a baseline ultrasound 2 years down the line and someone's calling you with new symptoms concerning for a new DVT. But just remembering that we really don't use it for duration of anticoagulation and making sure we're clearly explaining that to patients before sending them for an ultrasound. Because if they look at the report and they see all of these things and they're like, why are you not putting me on anticoagulation? That can lead to a lot of confusion. Thrombophilia testing. So this is a quote from Dr. Jean Connors, who's a hematologist up at the Brigham, who's been a leader in this space. And this was her New England Journal publication on thrombophilia testing published in 2017. And this was the first sentence of her manuscript. It said, ordering thrombophilia tests is easy. Determining whom to test and how to use the results is not. And so that's often what I come back to is it's really easy to click those buttons, but you got to be ready to understand how you're going to use that information if you are going to click the buttons. So just remembering when we're talking about thrombophilias, they're not a homogeneous group. So oftentimes if you have a thrombophilia panel like we do here at UAB, it includes these tests, but just remembering that there's differences here. So there are in this light green circle, these are our inherited thrombophilias, right? So factor V Leiden, prothrombin, protein C, S, and antithrombin deficiency. Antiphospholipid syndrome often gets looped into that panel, but this is an acquired disorder, right? So your family history should not be part of your decision-making for testing for antiphospholipid syndrome because it's an acquired condition. Within the inherited thrombophilias, we have what we consider our weak thrombophilias. So those are people who are heterozygous for factor V Leiden or prothrombin. And then we have what we would consider to be our strong thrombophilias. So these are in the inherited space, people who are homozygous for factor V Leiden and prothrombin, or if they're compound heterozygotes. And then in general, antithrombin, protein C, and protein S deficiency. And antiphospholipid syndrome is an acquired condition that's considered to be a strong thrombophilia. The important thing is that there's a lot of variation, particularly within the inherited thrombophilias, of how prothrombotic a patient is. Depends very much on family history. So I have a couple of patients who, have that come from families with antithrombin deficiency, and it is everybody. It is just like marching along. Everybody has, VTE history and was found to have antithrombin deficiency, as opposed to some patients where I have diagnosed protein S deficiency newly and they don't have any family history. And so we know there's difference in kind of the penetrance or the specific mutations that cause these different disorders. So they're not homogeneous either. And I think that's really important to keep in mind. There are a lot of things we recommend not testing for. And you will see, and at least in my practice, and I'm not sure in the pediatric population, I'm sure we see a lot of testing for conditions that we don't do anything about. That includes the MTHFR polymorphisms. That includes looking at factor VIII elevations. That includes looking at the PAI1 promoter polymorphisms. We see a lot of testing for that in the adult population, and none of it is actionable. And the biggest thing is ensuring accurate interpretation of results and remembering that a lot of our tests are functional assays. So that's in general, protein C, S, antithrombin, APCR, which is the screening assay for factor V, and the lupus anticoagulant can be influenced by factors including acute thrombosis, anticoagulation, pregnancy. And so we really should not be testing for these unless we understand the limitations of the assay to make sure that we're testing at the appropriate period of time. This is a quote from the ASH guidelines, and it says the results of thrombophilia tests should be interpreted with knowledge of the clinical pitfalls of laboratory testing. And I think that's really essential. So keeping that in mind, so the ASH guidelines for thrombophilia testing came out with a lot of fanfare and controversy. There's a lot of debate about how to interpret these guidelines, and I'm going to talk a little bit about that. But in general, there's kind of some clear no's where you don't need to test, and then there's a lot of uncertainty after that. So, and you can see here, the way I put this table together is, what do the ASH guidelines say? Remembering that they are all conditional with very low certainty of evidence, and versus kind of what is the discussion within the hematology community? How are we interpreting these guidelines and putting them into clinical practice? So if a patient has an unprovoked VTE or a VTE provoked by surgery, we are not testing that patient. ASH says no thank you. Doesn't affect our duration of anticoagulation. Limited duration is appropriate, and everybody seems to really accept that, right? You have a patient with a major surgery, they have limited duration anticoagulation. If they have an unprovoked VTE and you're keeping that person on anticoagulation indefinitely, then you don't need to test. Where the guidelines get a little bit hazy is VTE provoked by a non-surgical major risk factor. So that includes things like a prolonged hospitalization, VTE provoked by pregnancy or postpartum, or VTE in the setting of combined hormonal contraceptive use. ASH actually does recommend testing for inherited thrombophilias to guide the duration of anticoagulation. That has generated a lot of controversy, and I'll kind of talk through the nuance of it has somewhat shifted my practice, but there are still patients that I feel comfortable ultimately stopping anticoagulation even without thrombophilia testing. The guidelines also talk about cerebral and splanchnic vein thrombosis, kind of give you you can test, and that's pretty universal. There's just not enough data there to really tell us what to do in these abnormal sites. So just to highlight, I think this guideline is really interesting and important to understand how they generated the recommendations. And you can see here, so this was taken from the guidelines, and they looked at, in this specific question, women with VTE provoked by pregnancy or postpartum, should thrombophilia testing be performed to guide treatment? And so important to look at how this is phrased is that for women with VTE provoked by pregnancy or postpartum who have completed primary treatment, right? Everybody gets that first 3 to 6 months of anticoagulation. The ASH guideline panel suggests thrombophilia testing to guide anticoagulation treatment duration. So the panel suggests indefinite anticoagulation for women with a thrombophilia and stopping anticoagulation for women without a thrombophilia. Again, conditional recommendation, very low certainty of evidence. Importantly, how did they come up with these recommendations? There were no randomized trials available, right? So they used a modeling approach They used observational evidence and kind of did this risk calculation. What was the VTE risk of recurrence based on the observational data? What is the major bleeding risk? If the VTE risk outweighs the major bleeding risk, then you recommend indefinite anticoagulation. And so you can see here in this population, the VTE recurrence risk was based on observational data 50 per 1,000 at 1 year after VTE, where the major bleeding risk in someone with a presumed low bleeding risk was 5 per 1,000, excuse me. And so the calculus says, well, then we would keep them on indefinite anticoagulation. The challenge here is that I just told you that thrombophilias are not a homogeneous population. And so do I say, well, if a patient is heterozygous for factor V Leiden, am I going to keep them on indefinite anticoagulation, even though I know that doesn't increase their risk in the same way that, say, a patient who's homozygous for factor V Leiden? Does it depend on their family history? So actually taking these guidelines to practice can be really challenging. So in general, I still follow this algorithm from Dr. Connors from 2017. It's kind of how I think about it. And so if a patient has a first VTE and it's provoked by kind of strong factors, you're going to keep them on anticoagulation. There's really no role for testing in these patients. If they had, it was provoked by weak triggers in a young patient with strong family history and female family members of childbearing age. So a lot of considerations within that. The reason for that is that theoretically, if the weak factors, you're worried about an inherited thrombophilia, maybe it's not going to affect the treatment of that patient, but maybe it is going to affect the female family members of childbearing age within their family if they were found to have a thrombophilia. And the reason for that is, why do we say female? Well, because they have the ability to receive birth control at some point. And so will it affect their birth control selection options? And the other thing is during pregnancy, there are some of the strong thrombophilias where we recommend primary prevention with anticoagulation in pregnancy, even if they've never had a clot themselves. It is in general in those stronger thrombophilia, if they're just heterozygous for factor V Leiden, we don't care about that. But in a patient with a family history and a protein C deficiency becomes pregnant, even though they've never had a VTE, ASH guidelines recommend we put them on anticoagulation. So really understanding who this has implications for, not just your patient, but their family, is important. I always kind of joke when I'm asking the history is like, I don't care about the male children. It doesn't really change anything. But some people really just want to know for their male children and to be able to inform their risk. But the other thing that I always remind patients is that just even if I send thrombophilia testing for you and it's negative, it doesn't mean that your family member doesn't have an increased risk of VTE, because they do. Just having a first degree relative with a history of VTE is associated with increased risk. So it's really very much a shared decision-making process, but these are things that I think about. And so, right, so the first step here, it really requires a thorough history. You have to understand the patient, understand their family, and understand their risk factors. And then here, right, we're not jumping to testing, we're determining the role of testing, which to me is asking myself, is this testing going to change how I manage this patient? And so, right, just a reminder, right, if the duration of anticoagulation really in the past has not been influenced by thrombophilia, but like if you have a patient that has a massive unprovoked PE, you plan on keeping indefinite anticoagulation. So what is testing going to do for you? But it's really with these people with weak risk factors, with concern for a strong family history, or if you have an unprovoked event and you're trying to get them off anticoagulation. And you can see here are kind of the different testing that's recommended. The important thing here is kind of the mention of thinking about antiphospholipid syndrome separately. That's not mentioned in the ASH guidelines. The ASH guidelines are just about inherited thrombophilias. And so you might think about that really because it changes your management at this point, because we favor things like warfarin over the direct oral anticoagulants. So we are seeing a lot more testing for consideration of that. Again, in unusual sites, we're usually thinking about testing, but the important thing to remember here is that we're thinking about other things that are not inherited thrombophilias. So particularly in the splanchnic veins, we think of other conditions like myeloproliferative disorders. We think of paroxysmal nocturnal hemoglobinuria. And so other things that are not on that kind of pretty thrombophilia panel that you have already built for you. So we have to really use our critical mind in thinking about these unusual sites of thrombosis. Questions on, before I jump into that, thrombophilia testing, how do you feel?
Pediatrics, grandmother with a thrombus, we want the baby tested.
Yep.
We get at least 5 referrals a month on.
To you.
Yeah, so it's really frustrating to be like, this isn't gonna, it's so low in pediatrics of it happening.
Right.
An increased risk, it's not gonna change management.
Right.
Wait till somebody is of age to make an ethical decision about testing, which families usually do not accept that.
Do not like that, yeah.
I'm here, I want.
Right. Well, and it's hard because they get to you being told that they're going to, that's what we run into. It's like, I'm here to get my testing done. And so pulling back from that is really hard when the other providers have already kind of laid the groundwork for that. Yeah. That's interesting. And so then, if you find a baby with heterozygous factor V Leiden, how does that count? I mean, I know you don't do anything about it, but I'm just interested how families respond to that. But I guess it's probably variable. Yeah, a lot. Exactly. And then it generates years of anxiety for, yes. Yeah, exactly. No one ever gets to the beach because they're just stopping to stretch their legs. Yes, absolutely. So it's a really challenging topic. And I will say in the adult population, I communicate with our adult sickle cell providers, and sometimes it is questions about, and we just want to know, like, why did this happen? But I think it's rare to find something that's actionable. The important thing to know too is, just our understanding of thrombophilias is really more in the white population than it is in people of other populations. And we know factor V Leiden and prothrombin mutations are more common in the white population than they are in non-white populations. Interestingly, protein CNS is really common in like the Asian populations. And so there's different prevalences to consider too. But I think in our sickle cell population, it is more rare that we even find an inherited thrombophilia. Mm-hmm. All right. IVC filters, just going to touch on that because this comes up a lot. My rules of IVC filters is you only put them in if you absolutely have to. And absolutely have to is that a patient has an absolute contraindication to anticoagulation. And I think this is not really debated as much anymore, but I will say in the adult world, we find IVC filters just kind of finding their way into patients. And so my job often is just working to advocate to get them out as soon as possible. Just remembering as soon as you can restart anticoagulation, if you've put a filter in, you want it to come out. This is a scary picture where we have a connection between an aorta and an inferior vena cava due to a filter that yes, bad things can happen. And just remembering that there's a window of time where ultimately these become endothelialized and you can't remove them. And so I have a lot of patients who've had a filter for 10 years and they come to see me and there's nothing you can do about that. Hopefully it won't cause any problems. But I will say in my practice, I don't think I've placed an IVC filter in the past 6 months. It's really, usually for us, it's like a patient with a active intracranial bleed and a new DVT. But outside of that, we're rarely placing them. Okay. So those were the big topics I thought we would talk about today. If there's any other kind of VTE related thoughts or questions, happy to discuss those too.
I might have missed this.
Yeah.
So,
Lots of things.
how do you approach VTE prophylaxis in our pregnant patients with sickle cell disease,
Mm-hmm.
which sometimes is relevant on our side?
Yes, absolutely.
That's my first question.
Yeah, so that's a great question. So basically you're talking about primary prophylaxis for pregnant patients for VTE. And I know there's been kind of newer attention in this space. I'd be interested, and I don't know if any of our adult providers are on the call, if we are doing it. I'm not aware if we are. Interesting. And I know Dr. Peeker, I think, up at Hopkins has done some investigation into this question. And there is an increased risk in pregnancy compared to people without sickle cell disease. But the question is it a high enough risk to warrant anticoagulation, which comes with complications? Would love to know if in your experience or thoughts, if y'all have encountered this or what you think about it. No, not doing it. Yeah. No, but I think it's a conversation. The challenge, and even within the thrombophilias, so pregnancy in general, there's a lot of disagreement on who gets prophylaxis. So if you compare the guidelines from the American Society of Hematology with the American College of Obstetrics and Gynecology, they give two very different recommendations. But what I like about the ASH guidelines is that they give you a risk threshold over, like, it's numerical, that like, if I think the numbers, and I'll have to pull up the guidelines, I think if the risk of VTE during pregnancy or in the postpartum period, I think it's like greater than 1 to 2%. I forget the exact cutoffs. Like that's their threshold. Whereas like in the ACOG guidelines, it's like a little bit vague. Like, oh, you could think about it. So I think it's really theoretically an understanding and quantification of the risk of VT in a patient with sickle cell, and then maybe kind of extrapolating that. But I think we just don't even really fully understand what that incidence is. Yeah, it's a great question. The important thing to remember too, and that I always remind patients, is that actually we always focus on pregnancy, but it's really that postpartum period that's the highest risk period of time. So that 6 weeks postpartum is really when we see that risk go up. And so even just counseling patients to be aware in that particularly postpartum state, because that's when they're, we let them disappear for 6 weeks oftentimes. And that's the highest risk period of time. Great question. Great. Thank y'all so much. Really appreciate it. Okay. Should I close out or do you need to do anything else?
You have it.
All right.